The study we will be conducting will be a cohort study, and it will look at prediabetes conversion to type 2 diabetes in children ages 11 to 17. The purpose of the study will be to assess risk factors for conversion of prediabetes to type 2 diabetes mellitus in children ages 11 to 17 years of age in a cohort study setting. Our hypothesis is that factors such as excess dietary intake, lack of physical activity, increase in BMI, and abnormal C-reactive protein and insulin levels will augment the risk of a prediabetic individual converting to type 2 diabetes mellitus. The study duration will be 7 years. This figure gives an accurate representation of our hypothesis. We can see that excess dietary intake, a sedentary lifestyle, and genetic factors can lead an overweight individual to become obese over time, which leads to insulin resistance, and this ultimately results in type 2 diabetes. The exposure variable dietary intake will be measured by the Harvard Service Food Frequency Questionnaire for children. Physical activity and inactivity will be measured by the Actigraph GT3X Plus accelerometer. C-reactive protein levels will be measured by the highly sensitive CRP test. Blood insulin levels will be measured by C-peptide blood levels. Obesity will be measured by body mass index, and prediabetes or diabetes presence will be measured by the oral glucose tolerance test. All variables will be assessed at baseline with the exception of PAI or physical activity inactivity. Due to the nature of children's physical activity, short burst activity, that can lead to inaccurate estimates when based on memory alone, PAI baseline will be established from accelerometer data following first month's usage. To prevent information bias for PAI baseline data, participants will be encouraged to continue with their daily routines. PAI and dietary intake will be recorded on a monthly basis during visits with participants, whereas all other variables will be measured annually. Individuals in the study will be subjected to an OGT test at baseline and then once every year after that. Based on their blood glucose levels from the OGT test, the subjects will be classified into one of the following categories: normal glucose tolerance, prediabetes, and diabetes. Individuals with diabetic glucose levels at baseline will be excluded from the study due to the annual assessment of diabetes, if any exists. The time of onset of the disease will be considered as the midpoint between the date of the last examination without diabetes and the date at which diabetes is diagnosed. Diabetes-free time will be considered as the time between the baseline screening data and the date of final study examination without diabetes. The OGTT will be given to selected participants. The participant will be asked to avoid consumption of food and beverages for at least 8 hours prior to drawing blood. Participant will drink 75 grams of glucose and will wait 2 hours. At that time, blood will be drawn again. An OGTT value equal or larger than 200 mg per deciliter is a diagnosis for type 2 diabetes mellitus. We chose OGTT because it reflects the pathophysiology of diabetes better than any other test, since it measures blood glucose directly and indicates pancreas beta cell function impairment. BMI or body mass index is calculated as body weight in kilograms divided by the square of height in meters, and the unit of measurement is kilograms per square meter. The adult classification is not used for children and adolescents. As we can see in this figure, normal range for children is considered anywhere from the 5th percentile to just under the 85th percentile. At risk for being obese is from the 85th percentile to just under the 95th percentile, and anything above the 95th percentile is considered obese. We chose BMI because the components of BMI, which is height and weight, are simple to calculate. The methods are inexpensive, it is non-invasive, and can be done relatively quickly and has a wide applicability to screen large study populations. C-peptide is synthesized in the pancreas along with insulin. It can be used as a surrogate measure for serum insulin levels. We chose C-peptide because C-peptide's only source is the pancreas, and it is a more reliable measurement of pancreatic function than insulin. Furthermore, it does not metabolize in the body to the extent that insulin does, and thus provides us with a better estimate of blood insulin levels. C-reactive protein is a non-specific marker of systemic inflammation. Elevated levels are present in diabetes and hyperglycemia. The highly sensitive CRP is the most sensitive blood test to detect CRP levels. The HS-CRP method was selected because its sensitivity and specificity is relatively high compared to the other tests. Specificity for hsCRP in the identification of metabolic syndrome ranges from 71 to 74%. In obese individuals, hsCRP sensitivity to detect impaired glucose tolerance is 81%, but the specificity is low, at 46%. Due to the nature of children's activity and children's limited ability for recall, objective techniques are recommended for the assessments of their physical activity. An accelerometer, and in this case, the Actigraph GT3X Plus, will do just that. It measures the amount, intensity, frequency, and duration of human movement and is an excellent source for providing accurate estimates of physical activity over prolonged periods of time. Dietary intake is defined as a daily intake of nutrients such as vitamins, protein, and fats, and other food components such as fiber. To measure dietary intake, we specifically are going to be using the validated Harvard Service Food Frequency Questionnaire General Child Form, which is self-administered and available in English and Spanish, as well as match the needs of our study. We chose the Food Frequency Questionnaire method because it can be filled in less time than a diet history, can be delivered by mail, and processed electronically, as well as repeated at various times throughout the study. Our causal model for our study is presented here. We can see that excess calories, a sedentary lifestyle, genetic factors, as well as obesity, from the top towards the right, can lead to insulin resistance. Insulin resistance in the body requires increased amounts of insulin to process ingested glucose. As a result, the pancreas produces excess insulin to meet insulin demands until it becomes jaded over time, where consequently insulin levels decrease. Blood glucose levels thereafter, uncontrolled due to the lack of pancreatic insulin production, increase first to prediabetes levels and then naturally progress to hyperglycemia or type 2 diabetes mellitus. Hyperglycemia and products of adipose tissue destruction cause systematic inflammation and atheromatous deposits in blood vessels, which eventually lead to cardiovascular disease. At the conclusion of the study, we hope to have a better understanding of the risk factors leading to the conversion of prediabetes to type 2 diabetes mellitus among children 11 to 17 years of age. This will result in better prevention campaigns against type 2 diabetes mellitus among the pediatric population.